Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. All right, my favorite learners, in this episode, I had the absolute honor of sitting down with Dr. Carrie Bowman Dalley, PhD, CRNA, a true pharmacology powerhouse. Dr. Bowman Dalley is the program director and associate professor of the DNAP program at Georgetown University, where she's been shaping the next generation of CRNAs since 2006. She served in nearly every leadership role imaginable: assistant program director, research director, outcomes and teachings director, and currently leads the pharmacology coursework as the course director for both anesthesia pharmacology and advanced pharmacology. With a PhD in pharm, years of clinical experience, and national recognition for innovation and excellence in teaching, Dr. Bowman Dalley brings unmatched clarity to the foundational concepts that often trip students up. In this episode, she walks us through the basics of pharmacology in a way that is so easy to understand. And all I have to say is that she is a personal role model for me as both an educator and lifelong learner. Let's jump into the conversation. Hello, my favorite learners. I am super excited today to share this topic of anesthesia this morning in nurse anesthesia pharmacology. Today, we're going to be going over the foundations with Dr. Bowman Dalley. She comes to us from Georgetown University as a program director. So can you tell us a little bit about your background? Thank you for being here, and where your passion for nurse anesthesia education came from.
Well, thank you so much for having me. I love talking pharmacology, could do that all day. I think that's one of my regrets about becoming I love being a program director, don't get me wrong, but I had to give up some of my teaching time, and that's, I absolutely love talking pharmacology. So I started as a BSN grad from University of Washington in Seattle. And actually, a lot of my professors there were bench scientists. And so, one of my professors had written our textbook on pathophysiology, I think. And so, I always looked up to nurses who also were bench scientists. And it was something I always had as a goal, just as them as sort of my mentors. And then I came to anesthesia school here at Georgetown. I was a grad of the master's program back in 2004. And what I realized is I absolutely loved pharm. It was probably my favorite class. And then when I came back to teach, it was my favorite thing to teach. But the reason I decided to get a PhD in pharmacology and really understand it at that level was, I find that often when people are teaching pharmacology, you either have someone who really understands the bench science side really well, or you have someone who understands the clinical side really well. And so I've had professors, nursing professors that were amazing at helping me understand the nursing considerations, or in anesthesia school, the anesthesia considerations. But, sometimes the mechanistic piece was, I just couldn't quite get to the level I wanted as a student always with that professor. And then you'd have the bench scientists who were fabulous at explaining the mechanisms. But then when it came to how do you apply this, they really didn't fully have that piece. So I really wanted to be able to teach pharmacology from both perspectives. And so I've had a lot of fun doing so. I graduated from the PhD program here in 2017, but I've been teaching nurse anesthesia students since 2006. And it's one of those things that just never feels like a job to me. I would do it for fun. I really enjoy talking pharm.
Yeah, that is, it's inspirational for me to hear you say that, because I hope too that I can, because I'm more clinical based. So now I hope that with my students, that's a great way to put it, to take both components, the science and the clinical, put it together so that students can learn holistically pharmacology. I love how you put that. So thank you for sharing that. The first part we're going to go into is kind of defining some of the pharmacology basics, since this will be in their first quarter of pharmacology. So when we think about foundational pharmacologic terms, like pharmacokinetics or pharmacodynamics, what do you think every SRNA or anesthesia learner should have like locked in?
Think the advice I would give is, that first lecture that you get in pharmacology in your program, I would spend 3 or 4 times on that than you would another lecture, because understanding those concepts and really knowing what you're talking about when you talk about the cytochrome P450 system, or when your professor says this is excreted unchanged, like really knowing what that means, I think will make the rest of pharmacology so much easier for you. I think a lot of students make the mistake of, okay, they study it, they kind of get it, but then they move on to the next stop without fully grasping every single concept. And that's a huge disservice, because then you end up doing a ton of rote memorization, which maybe will get you to the right answer on a test, but then it won't be there anymore in 6 months, and it won't be there when you need it clinically. So I think the biggest advice is that first chapter in your textbook, that really covers pharmacokinetics and dynamics, or your first lecture from your professor. Just keep making sure you know the terms. And I think a good test for that is, okay, let's say you are in the OR and your colleagues are all around you, and a med student says, hey, can you explain this to me? Would you feel comfortable and confident doing so, or would you be a little shaky or embarrassed? And if you want to get to the point where you feel like you could confidently explain it in front of a room full of surgeons and feel 100% confident. So I think taking that time to really know it well. The other thing that I think is critical that a lot of people kind of skip over to their detriment is you have to know the physio and the patho that you're actually treating, and you have to know it really well. And, I think the way our programs are usually set up, I know for ours, we have physio the first semester. And then sometimes we're not getting back to the drugs that, manipulate that physio until semester later. And, students, we're all humans. And, you got that occasional really annoying person with a photographic memory, but I do not have that. And I think most students don't. And so, even if you did great and you got an A in physiology, by the time you get to the next semester, some of that's fuzzy. So really important to, before you start on any sort of class of drugs, make sure you take that just 30 minutes. It will be well spent reviewing the physiology and the patho. And that, I think, would be my best advice to people. The people who just wrote memorize the facts, sure, you'll get an A on the test, but it'll be gone.
Right. And
And
what
you
we do
won't know what you're doing.
Yeah, what we do in anesthesia is so particular. That's kind of how I'm kicking off my pharmacology classes, is like we can give any drug at any time at any dose. And, transitioning from bedside nursing into nurse anesthesia is a very different world in that way. And so that's
Yes.
kind of, I really want to emphasize the importance of that, again, clinically, because I do have a
Yes.
clinical background. So
Yes.
do you find that there's a particular drug classification that students tend to get tripped up on or kind of have a difficulty learning?
Yeah, there's probably 3, I think, that are really challenging, and you could probably relate, from your background, but I think volatile agents are really tough, just because the pharmacokinetics are not something most students have ever even thought about before. And there are a few things that really take a while to wrap your head around. And so I tell my students before I give that lecture, when I'm introducing volatile agents, like, I know it's hard sometimes to fit the reading in, but try your best to just like go over these terms in the book so that when I talk about them, you're going to catch on a little bit faster, because it's such a different way of thinking about drugs and pharmacokinetics. So I'd say that's a tough one. I think locals, for the same reason, usually we're thinking about giving a drug IV or even PO and trying to achieve a certain plasma concentration. And that's our goal, so we can get the drug to the brain or wherever we want it. But with locals, achieving a high plasma concentration is actually a very bad thing, because that leads to all the side effects. And that means the drug is leaving the site where we want it to work. So I think, we have students a lot of times with local anesthetics where they'll try to apply like protein binding, but it means something different. And so I think just making sure when you approach those drugs is sort of thinking about the goal, where we want the drug, where we don't want the drug, and how that's different. And then I would say the third class that's really tricky are ANS drugs. And I think those are particularly hard for former ICU nurses, because they know the drugs, they've used the drugs, but most ICU nurses, and this is a generality, not every ICU nurse, but I feel like most ICU nurses, are very accustomed to thinking about using the ANS drugs to treat a symptom, right? So, like the blood pressure's too low. We always give dopamine in my unit to bring the blood pressure up, or I work in a PICU and we use epinephrine to bring the blood pressure up. But in anesthesia school, which you already kind of mentioned as CRNAs, we have to decide the right drug and the right dose. There's no protocol really. We are looking at the patient and figuring it out. And so like for my students, I have to say, okay, I know like you have this example in the ICU where you use this drug and it did this to the blood pressure. Scratch all that. Your patient might have had sepsis. Your patient might have had 1,000 other things that your healthy patient coming in for plastics case does not have. So stop thinking that way. And instead, let's go back. What's the physiology? What's the pathophysiology? So we're not thinking the blood pressure's low, I need to treat it. We're saying the blood pressure's low. Why is the blood pressure most likely low? Is it too low because they're hemorrhaging? Is it too low because they're septic and vasodilated? Is it too low because their myocardium isn't contracting with enough force? And if it's low for those three reasons, you're going to choose 3 different drugs. And so I think I'm always encouraging my students to stop this kind of vague blood pressure's low, this brings blood pressure up, and instead really get to blood pressure's low because of this. I know this drug will have this specific effect on contractility or venous tone or arterial tone, and getting to like what specific thing is wrong and what drug is most likely going to target that. So yeah, I think those 3 classes are probably the 3 that I know I spend extra time teaching and really think about how I'm going to teach those in a different way than, I feel like the benzodiazepines, they're just a little more straightforward in terms
Right.
of what
Yeah, and
people are used
I
to.
love your answers to each one because I think it goes back to what you mentioned previously in that why physiology is so important, and that underlying knowledge of physiology goes into why our drugs work, how they work, and why we choose what we choose in the operating
Mhm.
room in those real life settings. Coming full circle here. I love it. It's like a beautiful picture. The next part we're going to go into is drug receptor interactions, kind of simplified. Again, we're going to go over just some key terms.
Mhm.
So some terms we throw around in pharmacology are affinity and efficacy. So
Mhm.
could you kind of walk us through the differences of those two in terms of pharmacology and drug interactions?
Yes, those are really important concepts to separate because you can have 2 drugs in 2 different directions in both of those categories. What I really recommend, I'm a very visual teacher, and so I recommend when you get to that topic, students, when you're studying and trying to learn the difference between affinity or potency and efficacy, is look at a dose response curve and try to interpret that dose response curve and what it means, because I think that can really help these click in a different way. But really, when we're talking about affinity, we're talking about how strong is the attraction between the receptor and the drug. And if you have a drug with a high affinity, that means there's a strong attraction. And so that also, is parallels potency, right? So a drug that is highly potent, you have a high affinity. And so essentially what that means is you can give less of the drug molecules to get the effect that you want. And usually that's a good thing in terms of side effects, because if a drug has a high affinity and you're giving less, that means there are less molecules to go off and do bad things and, cause problems with other receptors that we don't want, which leads to our side effects. So usually having a drug with a really high affinity is a good thing. It means it's potent. So if most ICU nurses, you've given morphine, you've given fentanyl, you give fentanyl in micrograms, you give morphine in milligrams. You give fentanyl in micrograms because it has a really high affinity for that receptor, and so the probability it's going to bind with that receptor is much higher than morphine, which we give in milligrams. So that's affinity. And then efficacy is just how well does the drug work? What is that max drug response you can get? And so, morphine and fentanyl, I was saying they have different potencies, but they actually have equal efficacy if you give an equal analgesic dose. So, and so you can get to that same efficacy. Now, you could argue people have different genetics. Maybe in one person, one works better than the other. But, in the general population, they have the same level of efficacy. And efficacy is usually sort of the baseline for that is the full agonist. So and that's usually the prototype of the drug. So, we would consider, if you were thinking of a beta agonist of something that had full efficacy, like an epinephrine would be a full agonist at beta 1. So yeah, I would say those are the major differences. And it's important to note that you can have low potency drugs that are highly efficacious. You can also have high potency drugs that have low efficacy and are partial agonists. So really important to separate those out.
I love how you compared it to the milligrams versus micrograms, because I feel like that's something that ICU nurses going into anesthesia can kind of conceptualize, and just thinking about why do we give micrograms, tiny amount versus, or tiny dose rather, and affinity is why. So I love that connection, taking something old that they know and are familiar with and putting it into kind of a newer term. These are like pretty classic pharmacology terms, but just again, so important in nurse anesthesia. So I love how you said that. Are there any easy ways? So efficacy and affinity are like similar terms, and there's another set of terms that are kind of similar. So when talking about specificity and selectivity, are there any ways that you found that students can kind of differentiate those two?
Well, yeah, interestingly, I don't think really about specificity much in pharmacology. I think about specificity as much more important when interpreting lab tests. So specificity is sort of one of those things I think about when I'm teaching a health assessment lecture, and we're talking about how likely a test is to detect disease when there's disease present, and to not detect disease in people who actually don't have the disease. So I think of that more as, a lab test sort of concept. Whereas selectivity, I talk about daily, pretty much in every lecture for pharm. So selectivity is basically how selective is a drug for a very specific type of receptor. And we have, when you learn autonomic drugs, for example, you're going to learn we have alpha 1 and alpha 2 and beta 1 and beta 2 receptors. If you look at the structure, just the chemical structure, or the protein structure, I should say, not chemical, but the protein structure of an alpha 1 versus an alpha 2, they're going to have a lot of similarities in terms of their protein sequencing. And therefore, there's some drugs that will be attracted to both alpha 1 and alpha 2, so not be all that selective. Whereas they have designed drugs that are selective for alpha 1 over alpha 2 and beta 1 over beta 2. So selective is just, I've got a junior and a senior in college. So I guess you could look at, some colleges are highly selective and take students only with, very certain metrics. So, selectivity could be that with a drug. A drug that's highly selective means it's going to be selective for a very specific receptor. And generally that's a good thing, and it will help reduce side effects. Non-selective drugs, what that essentially means is it's going to hit more than usually the receptor you're going for. And I think a good example of that are beta blockers, right? So beta blockers really, I can't think of, I don't think there are really any reasons we want to usually in anesthesia target a beta 2 and block it. Like blocking beta 2 is usually not a good thing. Blocking beta 1 is usually what we're going for. So we usually want to lower the heart rate or decrease contractility. So we're trying to block beta 1. And then if we have a non-selective drug, it blocks both and we get a ton of side effects. If you only block the beta 1s and keep beta 2 free, then you're going to have less of those beta 2 side effects. So generally, pharmacologists are always working for a more selective drug. We've been trying to find a selective opioid drug for years, but it's hard to do that because a lot of drugs in similar classes just are so similar in terms of their protein structure. So the drugs will be attracted to both because they look very similar. Yeah.
That's awesome. I love the analogy of college admissions.
Yes.
I think CRNA students can understand.
Yes.
CRNA programs are very selective as well. So
Yes.
that's something that we can definitely conceptualize. So I love that. The next thing we're going to go through is the journey of a drug. So again, that pharmacokinetics. Can we talk kind of about or walk through the life of a drug after it's administered? So that absorption, distribution, metabolism, and excretion, and kind of the process in a way that learners can stick with.
Yeah. So that question, again, I could I would answer it very differently if we were talking about local anesthetics versus volatile agents versus PO or IV drugs. And so again, like reiterating the importance of really understanding these concepts, depending on how the drug's getting into the body and where we ultimately want it to go. So I think that is the first question you have to ask as a student, like, where do I really want this drug? What's my goal? Is it a high plasma concentration so that it can get to the brain? Is it a high plasma concentration so it can get to the neuromuscular junction? Is it I want it concentrated in the tissues and not in the plasma where it can go to the heart and brain and do all sorts of problems if it's a local, for example. So again, I think that's the first question. But like in classic PO or IV sort of pharmacology, absorption is the first step. So we prefer IV and anesthesia because we want to achieve a high plasma concentration, usually very quickly. So we get, usually if it's an anesthetic, the drug into the brain in a short period of time, and so that we have precise control. So it's really nice to give a drug IV. You get it, achieve a high plasma concentration within a minute or two. With if you're giving a drug PO, remember that drug has to be absorbed across the GI tract epithelial layer, and it can, depending on the physiochemistry of the drug, it may be absorbed better in the stomach versus the intestines, and so there's going to be a delay. If you have a weak acid, those drugs tend to be absorbed more from the stomach because a weak acid in an acidic environment will favor that non-ionized form. So, weak acid, you could say you're probably going to see the onset slightly faster than a weak base, which needs to wait until it comes out of the stomach into the, small intestine where you have a higher pH and you're going to convert more drug into the non-ionized and it'll go across. But either way, you've got like at least, 30 minutes or so for that process to occur. And then remember where that drug will go from the GI tract as it goes through the portal circulation and into the liver. And so if the liver's super efficient, call that a high extraction rate, hepatic extraction ratio, then the liver is going to metabolize a ton of it. And so sometimes if there's just a really high, we call it first pass effect, all that drug will be metabolized before it ever gets out of the liver. So the drug has to, go through the portal circulation into the liver, and then we get the plasma concentration. So again, that's like a 20 to 40 minute time period. Also depends how much food's in the stomach and a whole bunch of other stuff. And that's why in anesthesia, we like to give things IV. Another thing with absorption, just to keep in mind, is the sublingual route. That is very quick because that skips the portal circulation. It'll go right into the systemic circulation. So, if your patient was experiencing an angina attack and you wanted a really rapid onset of the nitroglycerin, sublingual is a great choice because it'll really rapidly go there. So that's kind of the tips with absorption. Another good absorption kind of thing to keep in mind is if you are giving a drug IM. I worked with a preceptor who would always give ephedrine IM. And remember, it has to be absorbed through the muscle, and that depends on blood flow of the muscle, et cetera. So IM absorption can be really impacted by a lot of local conditions and is a little unpredictable as well. So I guess those are the main absorption points. And then we go to distribution. Distribution really depends on lipid solubility. So if a drug is more non-ionized and more lipid soluble, and those are separate concepts but related. Non-ionized tends to go through lipid bilayers much easier, lipid solubility increased. So you're going to have a higher volume of distribution typically if you have non-ionized lipid soluble drugs, which means it will move, into the fat more readily. Sorry, I'm kind of going all over the place. But
Keep going.
so with an IV drug, so one thing that you have to keep in mind when you're giving an IV drug, think about where most of our blood flow is going. So most of our blood flow per minute is going to our vessel-rich group, which is like our brain and our heart and our kidneys and our liver. And so if I give a drug IV, it's going to very quickly go into the brain, right? Because most of the blood flow every minute is going to that highly perfused organ group. So about 25% of the blood flow every minute is going to the brain. So the brain is going to see it really quickly. And so the drug will go into the brain. But then as the plasma concentration falls, the drug moves back out of the brain. So, when you're learning propofol and some of your other induction drugs, you'll learn like people fall asleep in 30 seconds, right? Goes right across the blood-brain barrier, they go to sleep. But then if you don't give more, it starts to come out. It's not that it's out of the body or it's metabolized necessarily. It's just that it's moving down its concentration gradient. So when you're thinking about distribution, I think really important concepts are where's the blood flow going, what's the timing, etc. So that's kind of the biggest thing with distribution, I think, is kind of considering blood flow. And then where are we? Like metabolism. So metabolism, one thing I always want students to like think about with metabolism is you'll hear people say the drug gets broken down, and that's my pet peeve because drugs are not broken into a whole bunch of pieces. That's not what happens with metabolism. What metabolism is typically doing is converting a drug from a more non-polar, so more lipid-soluble form, to a more polar form or water-soluble so the kidneys can get rid of it. We want most anesthetic drugs are going to be really lipid-soluble because they got to get across the blood-brain barrier into the brain. But then for the body to get rid of it, we have to convert it to something that's more water-soluble because the kidneys will just keep reabsorbing it, right? And so the body metabolism, what it does is it converts that molecule, and it does through phase 1 and phase 2 reactions. Phase 1 reactions are they're really more simple, hydrolysis, oxidation reduction. But phase 2 involves conjugating that drug with a really polar group. So we'll, add a big bulky molecule and covalently bond it on. That's not breaking the drug down. It's making the drug huge and bulky and polar, and that helps us get rid of it. So I really encourage students to not use vague terms and try to use the most precise terms, because that will help you understand what's really happening instead of, kind of this vague notion of what's going on. So that's my metabolism. And then with elimination, I think the biggest thing to keep in mind is elimination is most important in anesthesia when a drug is eliminated unchanged. So if a drug is excreted unchanged, that means we don't metabolize it. That's what that means. So it comes in as a molecule, it goes out as the same molecule. And so if that's the case, then excretion, perfusion through the kidneys and all of that is really, really important. So for example, in someone with renal failure, if a drug is excreted unchanged, that's not a good drug for that person. If a drug is highly metabolized to inactive metabolites, I'm not as worried about it in renal failure. So I think those are kind of the highlights, I would say, at each of those stages. I could really make this into like a 10-hour thing, but
I love it. I could listen to you
now.
forever. This is so inspiring. I'm like, how do I make this? It's just so understandable. I love it. And the buzzword, I'm going to have that buzzword in my lectures and classrooms as well. Like, we're not breaking down here. Okay. Let's talk about what we're actually doing with the drugs. So since we've kind of talked about the process in normal conditions, we're going to go into some of the physiological. You kind of touched on it with like renal failure and different things, but so not every patient processes the drugs the same way in that like classic way. So can you talk about how some factors like age or obesity or some organ dysfunction like renal failure, as you mentioned, can really change the pharmacological responses in anesthesia?
Yeah, so all of those things can have a big impact. And I think, again, that's like when you're taking care of a patient, I think it just is really important for 1 minute to just sit there and say, where are they physiologically? Where are they pathophysiologically? And so when it comes to age, you're thinking, where are they physiologically? What is their body composition? What's going on with them right now in terms of their development? And so when you think about a neonates have an extremely high total body water compared to adults. They have very low muscle mass and really low fat content. So when we think about volume of distribution, drugs we rely on redistribution to the fat, for pharmacokinetics in adults, it's not going to be the same in neonates. So just their body composition is so different. Their blood-brain barrier is immature. So their cytochrome P450 system, which is really important in terms of metabolizing those drugs, particularly the phase 1 interactions, those are often, immature. So a neonate is going to respond very differently to drugs than even a baby that's like 2 or 3 months old who now has gained some fat, who has a blood-brain barrier that's maturing. Um, so I think thinking about just like how the drug's going to be distributed is important, but also thinking about the physiology of the child. So remember, when we're born, we have our parasympathetic nervous system is pretty intact. Our sympathetic nervous system is not there yet. And so babies, anyone who's a PICU nurse will know this, like you look at them wrong and they'll have bradycardia. Whereas an adult, you look at them wrong and their heart rate's like 150. So you have to kind of think, where is their sympathetic tone? And then, what is their myocardium like? Neonates are very heart rate dependent. Their contractility isn't as strong. So if I blast them with a huge dose of an induction agent that has a major myocardial suppressive effect, I could really get that neonate into trouble. But fast forward 9 months and you've got a cute little fat baby who has, now crazy metabolism, really efficient cytochrome P450 system, really healthy young kidneys that, are very effective. Now we're talking about much higher doses. So again, you can't even group infants in the same category. You have to say, are we in month 1? And then, as you move into adulthood and then as patients age, then you start to think of normal changes with aging. And so our elderly patients, like, we expect every decade a decline in renal function. Even in the most healthy 90-year-old, we cannot expect the same renal function. And so you kind of just have to plan for that. The only caveat I would make is just be careful when you're making these generalizations, because an 18-year-old can surprise you. And I've had 90-year-olds surprise me, where, you think you need to be so cautious. And then it's like, oh my gosh.
So true.
So I think any experienced CRNA has experienced that, where, you're just, you see this like 95-year-old and you're like, okay, I'm going to go light on this propofol today. And then they just shock you.
Wide awake. It's like the nightmares you have where you're pushing propofol and they're like, won't fall asleep. Yeah.
Yes. Like, what is off with this formula today?
Was this expired? You're checking the vials.
So yeah, I would say never get too confident in like what generalities you're making on these. But at the same time, a lot of the time it is true. And you do need to be really cautious and aware. With obesity, for example, my biggest concern with obese patients is just their really high metabolic rate. They just desaturate so quickly. I think, you can say a lot about volume distribution and things, but honestly, the most important thing in that population is just being careful titrating any sort of respiratory depressant drug, because they just do not have that same buffer for apnea that our, normal weight patients do. So just being really careful with that. And then with renal disease, I think, just looking again, how important are those kidneys in terms of us processing, going through the excretion and clearance process. And if it's really important, then you're going to typically want to avoid those drugs.
Yeah, and I remember when I was a student, just talking about pharmacokinetics in general, my first experience where I was like, oh, wow, these concepts are actually really important clinically is I had a patient where her heart rate was 50 and I'm giving the propofol and I'm like, oh, like I'm having to give a lot and she's still awake, like she's not falling asleep. And it was that circulation time that it took, again, that physiology of and because I remember it was actually like the chief anesthesiologist that I was with that day, of course. And he's like, you just doubled her dose of induction for propofol. And I was like, she was still awake. And he's like, yeah, but the circulation time is slow. So even just those concepts that, again, we don't see in the ICU, and we have to change our mindset to really think about how the drugs are working and where they're going and how fast they're going there, so that we don't overdose or underdose patients is really important. So I appreciate all of your insight. This is just incredible.
Yeah, I had a similar thing with the circulation time when I was a brand new CRNA. I had a patient who was, they were, I think it was a colonoscopy or something where they were causing that vasovagal. And my patient's heart rate had gone down to 42, and he was normally like in the high 60s. So I'm like, oh, I'll just give some glycopyrrolate, and that onset is about 3 minutes, and his heart rate was super low. So it wasn't kicking in. And then all of a sudden the heart rate went to like 29. And then I went to atropine, but then the atropine took forever. And I'm like, oh, I wish I would have started with the atropine. But, you know, it's one of those moments where, you know, if you need something to happen quickly and the heart rate's low,
Yeah.
just go with the atropine.
Right. Yeah. And that's when
Yeah.
those onsets matter and the
They
timing
really
of it.
do.
So you're not chasing we've all been in the OR chasing our tail where we're now like, now we're giving this, now we're giving that, and giving it time, or understanding the onset time is and circulation time, all of those components together so that we can safely treat patients,
Yes.
and
Yeah.
quickly when we need
Yes.
to. So the next part we're going to go into, and then I'll kind of go through some rapid fire questions with you, is you touched on it already again, but we'll kind of go deeper because I feel like it's something that's really important and, again, new to anesthesia learners, is ionization and lipid solubility. So can you go a little bit deeper? Again, you've already mentioned it, but how the physiochemical properties actually affect that absorption and distribution of our drugs?
Yes. So, yeah, this is an area that I think, you know, students usually also have to spend some time in a very quiet room thinking things over. But for ionization, I think a good, you know, just thing to memorize that'll help you is knowing that, you know, if you have a weak acid in a relatively acidic environment, that is going to favor the non-ionized form. So if you have a match, weak acid, acidic environment, that match means you're going to favor the non-ionized form, which means you're going to have the drug that will easily pass through biological membranes, phospholipid membranes, because there's no charge. If you have a weak base and you have a relatively basic environment, that is also a match, and you'll favor the non-ionized form that easily is absorbed across a membrane. When you have the mismatch is when you start to see more drug in the ionized form. A weak acid in a basic environment, a weak base in a relatively acidic environment. I keep saying relative because that's really important. You have to look at something called a pKa. And a pKa is just a property of the drug. So it's just what it is. The pharmacologist measured it. Well, I'm 5'2", someone else is 5'8". That's just what it is. And that's pKa, right? And so pKa is the point that a drug is 50%, where a drug will be 50%, the pH, where a drug will be 50% ionized and 50% non-ionized. And so you have to look at where that pKa is and where the pH is. And then on top of that, you have to know if the drug's a weak acid or a weak base. So those three things are totally distinct. Ka, set characteristic, whatever pH the environment it is, whether the drug's a weak acid or a weak base, and that comparison. So the way those three things relate to one another. And again, without figures and things, I feel I have like 20 slides where I walk everyone through this. But yeah, I think, you know, if quick fire, you got a match, you're favoring the non-ionized form. You have a mismatch, you're favoring the ionized form.
I love that. It's a simple way to put it, for sure.
Yeah. And really, if it's more non-ionized, faster onset. It's going to get where you want it to go much faster. So like alfentanil, for example, is a super fast onset opioid, and that's because it's highly non-ionized at physiologic pH compared to the others. And it's really important local anesthetic pharmacology on onset. The closer the PK is to physiologic pH, the faster the onset. So bupivacaine's further away than lidocaine. Lidocaine's onset's faster.
I love that. And it's, again, so important how because I really want to emphasize to my students that these aren't just like really abstract concepts. They seem that way when you're learning them for the first time, but they actually relate to what we do and what we pick and why. And so understanding that is just, again, so important to know and understand it in a real terms and clinical terms, I guess. So you kind of mentioned it again, but so that's kind of why some drugs cross the blood-brain barrier more readily than others, correct? Or even the placental barrier. So
absolutely. Yes, absolutely. So the more non-ionized a drug is, the less protein bound it is. So, you know, if albumin and alpha-1 glycoprotein are holding on to it, it's not going to easily go across the placenta or the blood-brain barrier. And then lipid solubility. And a lot of students kind of conflate ionization status with lipid solubility, and they're related because if you're non-ionized and you're highly lipid soluble, you're going over, but they're separate. So you could have a drug that was non-ionized, but still, not necessarily as lipid soluble because it didn't have as many carbon atoms or something like that, so they are sort of distinct properties. And kind of going beyond your question here, but one thing that I think is really important for new students to recognize is don't make a generalization on one drug characteristic. Because I think I've had students say, oh, highly protein bound, that means it's going to have a small volume of distribution. And that's not necessarily true. I mean, protein binding will definitely limit volume of distribution to some degree, but lipid solubility is also important. Like there are other things that are important. So you kind of have to look at a drug in terms of all of its characteristics and then what characteristic tends to win out. And I think that is probably the most important thing. Students are like, okay, the PK is this, so this means this. And a really good example is chlorprocaine, which has a really high pKa, so you'd predict like a super slow onset, but we give it in such high concentrations. It's low potency, so you're giving a ton of it. So its onset's actually pretty fast despite that because you're just giving so many molecules. So the probability one gets over is higher. So again, like you have to be very careful that you're looking at every property as a whole.
Yeah, and I think students get overwhelmed with concepts and then they kind of do that generalization to try to get it down and again, kind of data dump and memorize. But if you get down to it, each drug is so different in its properties and knowing that is super important. So I love that. I'm going to go into some rapid fire questions here. So just a few more questions left. So what is one concept in pharmacology you think every SRNA should master first? Kind of a tough one.
Master first. I think one that I wish every student mastered in that first year is context-sensitive halftime. I think that's probably one of the more useful things to understand when you're have a patient, for example, on a propofol drip or a fentanyl infusion during a case, and you're that new SRNA or nurse anesthesia resident, and your preceptor's out of the room, and you gotta I think it's time to turn it off, but when do I turn it off? So context-sensitive halftime, I think, is one thing I would spend extra time in that first lecture. When you're getting all of these concepts, and it basically refers to essentially the longer you have the infusion going, the more that drug can distribute to inactive reservoirs like muscle and fat, and you can have a higher concentration there. And then when you turn the drip off, it starts coming back in and it will replenish the plasma concentration as the patient's metabolizing and eliminating it. So, if a propofol drip is on for 30 minutes, you turn it off, it's like a light switch. They're awake. If it's been on for 8 hours, you're going to have to plan and turn that off earlier. The patient is not going to wake up when you want them to. And so I think that is a big piece of it. Fentanyl is a really good example of that, of why context-sensitive halftime is really important and why an ICU nurse could get themselves in trouble at first. Because I think, a lot of people think of fentanyl as really short-acting, right? You give it 15, 20 minutes later, they're in pain again. Like it's short acting. Well, the reason is because it's redistributing to inactive sites. It's not because the body's getting rid of it really quickly. And so if you give enough fentanyl in an 8-hour case, it's going to no longer be short acting and your patient is not going to breathe. So, understanding context sensitive halftime, like how much fentanyl's on board is really important to understanding when it's going to wear off and when how your patient's going to respond when they wake up.
Yeah, I think that you just mentioned it as well, but I wish I would have known it in ICU and working in ICU because you have these patients that have been on propofol drips. We didn't use propofol because of the infusion syndrome and all of the things, but so we didn't use it for days and days and days. But when we did, you're like, this patient's acting crazy. And it's like, they're falling asleep and they're waking up and they're redistributing and trying to metabolize this drug. And so I always look back and I'm like, I kind of chuckle at myself because I'm like, the things you don't know that now you know.
Yeah.
It's just funny to look back and think about those things in the ICU. And maybe there'll be some ICU nurses that'll listen to this and they can learn something for their practice as well.
That's great.
So it's kind of similar, but I guess a little bit different. So one real world advice you'd give students who are overwhelmed by pharmacology.
Yeah, I think the advice would be physio and patho. I think it's so tempting. Nurse anesthesia students have so much they have to learn in such a short period of time. I know, like, you get in survival mode and you're like, I just need to learn this PowerPoint today. I just need to learn these facts about the drug that I know my professor is going to ask me on the test. What I really would encourage you to do, invest that time to review the physio and patho. I cannot tell you how valuable that is, not only in terms of just like doing well in the test, because you can do really well in the test with rote memorization. Most people who have like strong short-term memory or intermediate term memory, like where you can learn it really well for like 3 days and then 2 weeks later it's kind of gone. Anyone can do that, but that's not helpful. That physiopatho is so critical. And like, for example, when I teach ACE inhibitors and ARBs, I spend the first 10, 15 minutes teaching these drugs, just going over, okay, why do we release renin? What conditions stimulate renin release? And then how does angiotensin 1, how is it converted to angiotensin 2? And then where does angiotensin 2 go? And what does it do? And then in what situation do we want this to happen physiologically? And if you do that, then you don't have to memorize, like, these drugs cause hyperkalemia, because you can think like, okay, so I know my body releases a lot of renin when I'm really dehydrated because I need to hold on to sodium and water so I don't faint. And that's what my body's trying to do. And so if I block that, then I'm not reabsorbing sodium. And so instead of the sodium, the potassium's coming. And so you can kind of like reason, if you know the physio, you can picture it all and you don't have to memorize it. And I would really say that's super helpful for ANS physiology, like pharmacology. Do not try to learn ANS pharmacology without expending at least 2 hours. I'm serious, at least 2 hours reviewing ANS physiology, because that will save you a ton of memorization. I spend a ton of time on that. I took over teaching physio for ANS for my class, for my program, because I'm like, they need this like crazy foundation in ANS physiology so that they don't have to work so hard at memorizing pharm in that unit.
Yeah, and I've even preparing for my courses that start in the fall, I've had a really hard time like remembering that I'm not a physiology class at the same time. And I'm like, how much time do I spend like going into the physio? I know they're going to have this physio content. So I've kind of been working with our A&P professor as well to kind of make sure that they're matched a little bit.
That's
So
great.
they're not, just, so they're understanding that, and I'm not having to teach a pharm and physio class, but it's so important that they get both and they get that foundation in the physiology for sure. Okay, the last question, and I'm going to ask everybody that is a guest on this podcast, is one piece of advice you would give an SRNA in the middle of CRNA school. So kind of think back and like advice you may have given to yourself, thinking back to your experience, or just a words of encouragement.
Yeah. I think, that you can get so burned out. It's such a marathon. I think what's important is just focus on the challenge of the day and don't start to think too far into the future and like, what if. I find our students waste a lot of time with catastrophizing. Like, I think it's important to recognize the importance of the work we do and the high risk of the work we do. But also you can spend so much time doing that, you're not learning anything. And so I try to tell my students, every minute you're studying, every minute you're learning something new and constructively focusing, you might be saving a life in the future. So stop worrying about like what could happen, like whether or not you're going to remember this later on, or all the other things you have to do that day. Just focus on that moment, learning as much as you can. And remember, you don't have to learn everything in anesthesia school. I didn't, and I'm still learning every day. And so there's no harm. And I didn't get that really well. Didn't do that great on this concept first year of anesthesia school. Let me revisit that in second year. Well, I still don't really get it. Let's revisit that third year and you'll get there. So try to not be so hard on yourself. This is a lot. Some things are just so difficult to wrap your head around, and give yourself time and grace. And the other thing I would say is just never forget that your wellness is the absolute most important thing. Always. Anesthesia school can wait. Your wellness is really important. And anesthesia school tests that in every way possible. And so just making sure you carve out that time with people who fill your cup. You continue doing the things that keep you healthy, whether that's doing yoga or going for a walk or laughing at a comedy show, whatever does that for you and gets your blood pressure down. Don't, like, students think I have to be studying every hour of the day, and you do need to be studying many of the hours of the day, but make sure you schedule an appointment for your wellness throughout the week, so that you're not letting that go, and that you come talk to your professors if things are getting overwhelming, and don't try to, it's okay to not be okay is what I tell all my students.
Yeah, no, it's true. And I remember a clinical coordinator when I was in school told us, two things that you can do that are really simple to help your wellness is one, make your lunches. Like, it's going to be easy financially it's hard to buy foods, but they're so busy that eating hospital cafeteria food isn't as good as making it from home, which I didn't really listen to, but because you do what you can. But the second thing was take the stairs. So taking the stairs, I still always take the stairs, and I still always think of her because she was like, even just getting your heart rate up just a little bit, if you should be making time to exercise, but again, it's so hard, and prioritizing those things are important. I feel like we're better now than we were when I was in anesthesia school.
My gosh, yeah.
About prioritizing that.
Getting better.
Yes, but just little things that can help students, I think, will make an impact. Like just as simple as not taking the elevator and taking the stairs. So
no, I agree. And actually, there's some scientific evidence to suggest
scientists.
You have so if you take animals in these experiments and they have very low stress levels, like low levels of catecholamines and cortisol, they don't learn as well. And if you take like animals that are highly stressed and have really high levels of cortisol, really high levels of norepi, all of that, they don't learn very well. The animals that learn optimally have some stress. So they've got some catecholamines going. And so I go over my lectures on my elliptical machine because I'm convinced getting my, catecholamines up a little with the exercise helps me lay down memory. And it works for me. So do it safely. I wouldn't don't get injured trying to study while exercising.
There are so many tools now, like Anki, or I've just learned about Anki, so I'm looking into all of these tools. But you could go through Anki on a bike or on a treadmill walking. Yeah. I remember doing that in anesthesia school too, and I felt like I did retain information better if I was walking or just doing things. But again, safely, not texting and walking. Walk straight into the pole.
And sleep. I would just say one more thing. Sleep is so important. Students will cheat themselves of that, thinking that they should, stay up longer, learn something more. But it's very clear that you need sleep to consolidate your memories. And so if you want to learn something, do not skip the sleep. I can't tell you how many times I'm just I go to sleep, I wake up, I have a whole new way of organizing this in my brain, and it's making so much more sense.
Yeah, and when you're sleep deprived like that, and it's midnight and you're still studying, you're starting to spiral, and sleep is so important. I agree with you. Well, I thank you so much from the bottom of my heart for being here. This was so inspirational for me as a professor, and I know the students will just love this. So expect me to be bugging you again in the future when the students are begging to have you back. So
sure, and I hope to see you at in a national meeting soon.
Oh, yes, I'll meet you in person soon. So thank you so much. I appreciate your time.
All right, thank you, Dr. Gomez.
Bye. Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving, and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.